welcome to the award ceremony for the College of Pharmacy here at the University of Findlay. We were trying to estimate over lunch how many times this has been done. In this format, I think we decided, didn't we, that it was the third time? But there have been other formats prior to this. So we have honored our scholars every year for as long as anybody can remember here at the University of Findlay. It's an auspicious day, an important day, in which we recognize the achievements of our best and brightest students and faculty, frankly. In one day, perhaps we should honor them more completely all year long, and we try to, but today is special. Today is an important day. We stop class for a while to do this, close offices, and we gather here together to honor these people who have achieved great things. I want to start with some house rules. The students who have been here for a while already know the first one. If it rings, you owe me $25, so turn it off, and the $25 goes in the college scholarship fund. Believe me, I've already paid my $25. The order of business is we have an a distinguished alum coming back to visit for the day and to talk to you. Dr. Dudley, you are a real rotten. Dr. Dudley just placed a call to my cell phone. To tell you the truth, I thought I had his number blocked. The order of business today is to recognize that alum and ask her to offer a few minutes of conversation with you about her career, her thoughts on pharmacy, or whatever else somebody as distinguished as Dr. Mason would care to say. She and I spent a few minutes reminiscing about her life in the AMU when she was a student here, because she started here before there was a College of Pharmacy building. So this was their home for that first class for a year or two while they waited for the Davis Street building to start. Dr. Mason was also part of a group of three students, particularly three students, Amanda, Joe, and Jenny, who put together our accreditation application on the tailgate of Dr. Malone's pickup truck in the parking lot behind a house on Fraser Street. It was an interesting time. The application weighed 16 pounds per copy. It was a big deal. Those are things that I want to say about Dr. Mason. Now, Dr. Perry wants me to say some things about her as well, and I will do so. Jenny Mason is a pharmacist and a doctor of pharmacy. She has completed a PGY-1 residency in Florida, and she is currently in a PGY-2 residency at Nationwide Children's Hospital in Columbus, Ohio. She specializes in pediatrics, of course, and in particularly in emergency department pediatric care. She earned her Bachelor of Science in Pharmaceutical Sciences from The Ohio State University in Columbus and her Doctor of Pharmacy from the University of Findlay in 2010. She was, in fact, a member of our charter class. Following graduation, she completed her residency in Florida with a pediatric emphasis at Baptist Medical Center, Wolfson Children's Hospital in Jacksonville. Her areas of interest include pediatrics, emergency medicine, and toxicology. Her current research project focuses on the management and education of children in the emergency department following an asthma exacerbation. Last year, she conducted research in pain management with children undergoing blood draws and intravenous line insertion. She also enjoys working with pharmacy students during their clinical rotations, and in fact has had a pharmacy student this year, Elaine Steerhoff, is that correct? Yeah, I think so. Dr. Mason is actively pursuing a career in pediatric emergency medicine following the completion of her residency. She's originally from Lucasville, Ohio. By the way, I learned over lunch that she will continue as an emergency department pharmacist at Nationwide Children's once her residency, PGY-2, is finished. I am very pleased to be able to introduce to you Dr. Jenny Mason.
Thank you for that introduction. Good afternoon and welcome to the College of Pharmacy Awards Ceremony. As Dr. Stanzalski had mentioned, I'm currently a PGY2, so it's a second-year resident in pediatrics at Nationwide Children's Hospital. And I was asked to speak today on my decision about completing 2 years of residency and the role of the pediatric pharmacist. To give you a little bit of background, I am from a small town in southern Ohio, and I'd always had an interest in healthcare. Prior to starting at Findlay, I completed my bachelor's at Ohio State University. I truly enjoyed my time at Findlay. Coming from a large university such as Ohio State, I loved the fact that we had smaller classes. I was really able to get to know a lot of the professors and get that one-on-one attention that I sometimes may have needed. I enjoyed being a leader and involved in many organizations. And being at a new program, I had the opportunity to be able to do that and start many of the new student organizations here on campus. While I was here, I was heavily involved with ASP. So during pharmacy school, I had always knew that I had wanted to complete a residency. I wanted a career where I was able to be more clinically focused and really have that major decision or make decisions in patients' direct pharmacological therapy. So I would like to ask you a question for the students here with a show of hands. How many of you think you know what you want to do once you finish school? Okay, good. So a couple of you. I had always thought during school that I wanted to go into ambulatory care. During some of my IPPY hours, I had shadowed some pharmacists at St. Rita's and just really enjoyed that direct patient care that they had. And then when choosing my hub site, I really wanted to go to a place that would set me up for a residency focused. I knew I wanted more experience in hospital pharmacy. I knew I wanted experience in emergency medicine and in pediatrics. However, the hub site that I had been chosen to go to, they did not have that pediatric option. So I took the initiative to try to contact a couple pediatric pharmacists to see about setting up a rotation during my rotation years. And so I was able to complete a pediatric rotation in ambulatory care. And during that time, I was also able to talk to some of the pharmacy supervisors in that inpatient setting and found that if I had wanted to do pediatric focused in a second-year residency, I really needed that first year to be in the inpatient setting. So from a matter of probably like 2 or 3 days, my career path had changed from looking for an AmCare residency in Ohio to now looking at an inpatient residency that had some pediatric options throughout the country. As Dr. Stanzalski had mentioned, I completed my PGY1 first-year residency at an adult and pediatric institution in Jacksonville, Florida. And so because I was on this pediatric-focused track, I was able to have most of my rotations in pediatrics, although I did have some adult rotations as well as my staffing component on the weekends was at the adult hospital. So I really had a well-rounded first-year residency of both adult and pediatric patients. I was not sure at the beginning if I wanted to do a second year. I kind of had always had that in the back of my mind that if I wanted to go into pediatrics, I might need to complete that second year of residency. But several factors really came into play when deciding to do that second year. I had interviewed for both jobs and for second-year residencies, and had found out that I really was only qualified for about maybe half of the jobs in pediatrics. And none of those positions included being kind of that clinical specialist, so that expertise on pediatrics. So that was a big deciding factor. And then I had also had rotations as both a student and a first-year resident in adult emergency medicine. And I really liked that, and so I thought with my interest in emergency medicine and my interest in pediatrics, that pediatric emergency medicine just seemed like the best fit for both my career and my interest. So where it was at, we did not have a pediatric emergency medicine pharmacist. So I was able to talk to some of the physicians in the emergency department, my residency director, our clinical coordinator, some of the other preceptors, and was able to complete a rotation in the pediatric emergency department. And I had been the first resident at that hospital to do so. So once I started that, I immediately found that there were multiple interventions that I could make. And so knowing that I really had that interest in pediatric medicine, I knew that I needed some more critical care exposure and some more emergency medicine and toxicology exposure that a second-year residency would have. I also knew that from interviewing for other jobs that I was really only qualified for half of those. So I thought it was a good career option to spend another year learning and gaining more experience in that second year would take me further along in my path for the future, and that another year of sacrifice would set me up for a lifelong opportunity, and that just seemed like the right choice to me. So as a second-year resident, all of my rotations this year have been in pediatrics, and I've been able to strengthen the qualities that are needed and necessary to make a good pediatric pharmacist. So what is so special about being a pediatric pharmacist? So these pediatric pharmacists carry a very important role. You are a direct patient advocate. The majority of your patients cannot make their own medical decisions, so you have to make sure that you are there looking for the best interests of your patient and keeping all of that in mind when deciding their care. I treat patients down to 23 weeks of gestational age, and for those of you who may be kind of unfamiliar with that terminology, 40 weeks gestational age is the typical length of a pregnancy. So I treat patients that are a little over half of that to cardiac and cystic fibrosis patients who are 40 years old. So huge age span. That means that I have to dose stuff for patients who are under a pound to patients who are several hundred pounds. So a wide variety of knowledge is required. Looking at the pharmacokinetics, what we learn in school with adults can be very different for certain medications in the pediatric population. And even just pediatrics in general, those patients who are child and adolescent ages, even they have different pharmacokinetics than the smallest infant. The majority of what we do is dosed in milligram per kilo, so I have to be able to know how to dose that 1 pound baby in milligrams per kilo, but I also need to know how to dose those older patients, so teenagers and adolescents and the adult patients that I have. And I have to be able to recommend medication doses without going over that max adult range. We do a lot of individualized dosing for our patients, and so a lot of what I do might be doing multiple pharmacokinetic calculations daily for several different patients. And there's also a lot of disease states that are specific to the pediatric population. So for those instances, I have to know when I should be going over that adult max for specific indications. I also serve as a reference for many of my classmates when it comes to pediatric information, knowing the different doses and medications and how to do things for certain patients. And some of them are very surprised at how we might dose stuff. For instance, vancomycin, we start right out with giving every 6 hours, where in your typical adult patient, you might start twice a day, or there's elderly patients with bad renal function, maybe even once daily. And depending on the team or the service that I'm covering, because I switch rotations every month, I might be relied upon to recommend things that I'm not used to or I'm not comfortable with. So one example would be, I'm used to writing TPNs, and I can do TPNs pretty confidently. But during my NICU month, I was asked to make recommendations on patients' feeds and their formulas. Something I've never even thought that I would be doing. I had no idea of kind of what even this might entail. So there's always this lifelong learning. So I would have to be able to calculate how much feeds they should be getting, dose adjusting that, and how to make the calories different for adequate nutrition and growth. And then I would also have to look at that and see what nutritional requirements were in that, and if they needed any additional supplementation for like vitamins or iron. Also, as a pediatric pharmacist, a lot of times you need to be very innovative. Because there's not a lot of things that are studied in the pediatric populations, some things there's not a lot of information about on what therapy or how to dose a certain therapy should be the standard of care. So many times we are asked to come up with dosing regimens that really aren't available and that aren't out there. One that comes to mind in particular I had a patient, I think she was about 12 years old. She was in the ICU, and she was a cerebral palsy patient, so she was bedridden, had multiple wound infections, many different resistant bacteria, and they were wanting to do vancomycin and gentamicin bladder irrigations. And so bladder irrigation was something I had only learned about just last year. And I was used to and comfortable with doing aminoglycosides and the gentamicin that they had asked for, but I'd never heard of doing a vancomycin bladder irrigation. So after doing a thorough literature search, I could only find one patient case, and that was in a 60 or an 80-year-old patient, so an older woman who would be very different than a 12-year-old kid. So I had to come up with a regimen where there wasn't any information out there, but something that I thought would be safe for the patient. And so this is one thing I probably wish I would have paid a little bit more attention in school, was drug information, because not a day goes by that I probably am not involved in some type of drug information search in a pediatric patient. So very important, students. Right now, I feel I'm very lucky to be in an institution that has a great and excellent physician and pharmacist relationship. I'm constantly being sought out for recommendations for medications, as well as my thoughts and opinions just on therapy or the patient in general. The majority of my recommendations are taken without question, and usually if they're not taken, I'd say about another half of them the next day, they might decide to do that. I enjoy working with a large team that consists of the medical residents, the attendings, the fellows, med students, pharmacy students, nurses, dietitians, just a very vast team that I participate with. And I was recently hired on as the new pediatric emergency medicine pharmacist. And I'm very excited to start this new chapter in my career. And not only will I be able to take part in the excitement of the codes and traumas that go on in the emergency department, but I also have that ambulatory care component that I first really enjoyed for those patients who use that emergency department as their primary care. When looking at positions last year, nothing was available in pediatric emergency medicine, although a lot of people had said that's something that they were looking to for the future. And when I was looking for jobs this year, I found that there were only 4 pediatric emergency medicine positions available nationwide. So I feel pretty lucky to have found one where I'm at and to stay on. But I think I have my work cut out for me because they are not used to having a clinical pharmacist in the emergency department. They think that pharmacists really just verify orders, make sure the doses are okay. And so one thing that I'm really looking into doing, which kind of surprised me too, because I was not really huge in the research component, but I've already thought of several projects and research ideas that I would like to do for my first coming year. I would like to be able to justify my position and potentially justify additional emergency medicine positions. My goal is that we will have eventually 24-hour coverage in our emergency department. I want to make sure that that emergency medicine pharmacist is an integral role in the emergency department. With PEDS emergency medicine becoming an up-and-coming field, and where I'm at, we're building a new hospital. We'll be the second largest pediatric institution in the country. We'll have a brand new state-of-the-art emergency department. I think that'll give me a lot of opportunities, and my hope is that eventually our pediatric pharmacy practice model will become a model for other institutions nationwide. So many times you have to really to show your team what you can offer and to show as a pharmacist, what you can offer to those patients. And so if you only take one thing out of what I've spoke about today, I would hope it would be that if you have an interest in something, that you take the initiative to try to do it and to take it as far as you can. The worst that someone could tell you is no. So I would like to thank you for coming here today and for your time and attention. And if anyone has any questions, I would be happy to stay afterwards and talk to you. Thank you.